Hello, everyone. Hopefully you can hear me. Thank you all so much for joining. I'm going to say good morning from Sydney, Australia. As some of you know, my name is Vanathi Sivasubramaniam, and I'm an anatomical pathologist here in Sydney. And I'm sharing the moderating duties with the lovely Francesca Lunardi, who's in Italy and who's also at the current chair of the pathology professional community. And I'd like to welcome you to our webinar this morning entitled Artificial Intelligence in Thoracic Transplant Pathology, Hype or Real Utility. So we have got three wonderful speakers for you this morning, and I'd like to thank Francesca for organising this great array of speakers. I think you're all going to be very impressed with the topics. And so with no further ado, I'm going to hand over to Francesca. Just to let you know, we'll have all three speakers speaking to one after the other, and then you can save your questions for the end. And you can either use the chat facility, but if you want to, please feel free to ask the questions to any of the speakers. Francesca, I'll hand over to you.
Thank you, Vanathi, and welcome everyone to this webinar. Today's topic is both timely and exciting, as Vanathi told us. And I'm really looking forward to hearing from our exceptional colleagues who will share their expertise and perspectives. With that, it's my pleasure to introduce our first speaker, who is Dr. Elliot Pfister, and he is a transplant cardiologist and cardiovascular scientist at the Wesley Research Institute, with academic appointments at the University of Pennsylvania and the University of Queensland. He specializes in computational pathology, spatial biology, and artificial intelligence, in particular after heart transplantation. So, Elliot, the floor is yours.
Thank you for the kind introduction, Francesca, and a big thanks to you and to the ISHLT for organizing this great webinar. It's really a pleasure. Today, I'm going to focus on a fairly simple question. In a field where we already collect enormous amounts of tissue and clinical data, can AI help us extract more useful information from the data we already have? Heart transplantation is one of the most testing-intensive areas in medicine. In the first year alone, patients undergo dozens of diagnostic tests, lab works, biopsies, ECGs, echoes, imaging, and a variety of specialized molecular studies. All of this testing requires a substantial commitment of time and effort from patients and providers. And yet, despite this, post-transplant practice remains largely protocolized, one-size-fits-all experiences for our patients, with rejection and immunosuppression-related complications still occurring quite frequently despite all of the testing. This is what we might call an underachieving data-rich environment. We're investing tons of resources in collecting enormous amounts of data, but we're just not using it to its full potential. Patient care plans are reactive rather than proactive, with alterations in these plans triggered by events that have already occurred, rather than by risk profiles which predict events that will occur. And as a result, there's clearly a population of low-risk patients out there who are over-tested and over-treated, as well as a population of high-risk patients who are under-surveilled and who receive inappropriate or premature weaning of immunosuppression. This means that there's a real and often under-discussed burden of both waste and harm experienced by our patients, simply because of the inefficiency with which we leverage the data we already get from them. To derive more meaningful insights from our data, we need both new technologies and new conceptual frameworks. From a conceptual standpoint, each data modality, clinical data, tissue data, imaging data, molecular data, provides an important but incomplete glimpse into allograft biology. When those modalities are interpreted in isolation, we miss out on important complementary information. When we integrate these modalities, we have a chance to discover signals that no single data source captures on its own. And when we track these data modalities over time, we move from static measurements to dynamic trajectory-based assessments of allograft health. Advanced computational and AI tools are the technologies that will enable us to achieve these complex data synthesis tasks, converting large quantities of structured and unstructured data into individualized, actionable risk profiles that pave the way for more personalized post-transplant care. Among all the data streams we generate in post-transplant medicine, the biopsy remains the most information-rich and clinically important for rejection assessment. Unfortunately, in heart transplant, the way we currently extract information from biopsies captures only a fraction of the information that's actually contained within them. Histology is uniquely valuable because it captures the end product of all the underlying molecular biology. Detailed information on the combined effects of immune activity, myocyte injury, vascular change, and stromal remodeling are all encoded within histology samples. The ISHLT grading framework provides an essential shared language for summarizing that biology, but by design, ISHLT grades are compressed and simplistic readouts. When we ask pathologists to reduce a complex and spatially heterogeneous tissue into one of several categorical grades, we introduce familiar issues like inter-grader disagreement and limited clinical correlation into our patient care pathways. AI-aided computational pathology workflows offer an opportunity to address some of these limitations. When we digitize a histology slide, the histology sample becomes a mineable form of biomedical data. And this data can be analyzed using a variety of AI-powered image analysis tools, which can help us access, quantify, and standardize the information within them to uncover richer, more nuanced tissue phenotypes. Since I know there's mostly pathologists in attendance today, I'm going to address sort of one of the key points here. Computational pathology is often framed as AI tools doing the work of pathologists, but I think that framing misses the mark a bit. When we do it well, the real value of computational pathology is that it turns the art of histology into a quantitative science. As I mentioned on the last slide, histology already captures an enormous amount of integrated biology, and pathologists are experts at identifying the tissue patterns that summarize that integrated biology. What computational tools let us do is formalize the expert observations of pathologists by converting them into measurable features, which can then be analyzed at scale across thousands or millions of observations. Thus, rather than replacing pathologists, computational tools exist to help us scale and systematize pathologist expertise. Now, as I've been alluding to since the start of this talk, the larger opportunity here is not to use AI to analyze pathology in isolation. It's to use AI to convert the biopsy into a quantitative data stream that we can integrate with the rest of the data surrounding the patient. And with that broader multimodal framework in mind, I want to move on to some usage cases which highlight the potential of AI in transplant medicine. Our team's been working to apply multimodal data integration concepts for quite a few years now. Our first demonstration of this approach focused on cardiac allograft vasculopathy, or CAV. As most of you probably know, CAV is the leading cause of long-term transplanted heart failure and loss. The gold standard for diagnosing CAV is the detection of epicardial coronary disease via coronary angiography. But this is really only the gold standard because there aren't any validated ways to assess the earlier, subtler microvessel changes which precede overt large vessel disease. In order to explore whether AI-aided data integration could help us identify CAV patients sooner than traditional diagnostics, we applied computational pathology to routine one-year surveillance biopsies, extracting quantitative features of vascular morphology, perivascular cellularity, and stromal organization. And we combined these morphology features with a large set of structured clinical data extracted from the electronic health record. Using these two distinct data sources, we created three CAV prediction models. The first used just large clinical data, the second used just the quantitative computational morphology data, and the third integrated the clinical and morphology data to assess the added value of multimodal frameworks. The goal for each prediction model was to identify which patients would manifest overt high-grade CAV by the end of their 5th year after transplant, using only data available at the end of their 1st year post-transplant. As you can see, moving from left to right, the clinical model performs okay with an AUC of 0.7 and modest accuracy. The morphologic model definitely performs better, achieving a respectable AUC and accuracy of about 0.8. But it's really when we combine the predictive outputs that we produce our strongest model, which achieves an AUC of 0.93 and nearly 90% accuracy. This is real predictive performance here, functioning at a level of performance which could convince clinicians to alter surveillance and treatment strategies years in advance of overt CAV onset. In other words, it's the type of predictive performance that might enable a truly personalized medicine approach for individual transplant patients, potentially reducing the burden of unnecessary testing for some, while improving long-term outcomes for others via early initiation of disease-modifying CAV therapies. Building on the CAV work, we next wanted to move from integrating different data types at a single time point to integrating serial data as it accumulates over time. Due to the high risk of allograft and immunosuppression-related complications, patients are seen very frequently during their first 6 months after a transplant. This creates an ideal environment for testing the value of longitudinal or Bayesian logic, where risk is recalibrated as new information becomes available. So for our next experiment, the question really became, can we achieve accurate future acute rejection predictions by analyzing not only what the biopsy and clinical data tell us today, but how those measurements have changed over time? We studied more than 450 transplant patients across nearly 1,200 outpatient encounters. And at each encounter, we combined two major data domains: the clinical data comprised of extensive EHR data, and the morphologic domain, which used our computational pathology pipelines to extract hundreds of quantitative features pertaining to immune cell infiltration and stromal remodeling. For both clinical and morphologic domains, we modeled the current value and the rates of change over different time intervals since previous visits. So now we're not simply integrating across modalities, we are integrating patient-specific trajectories over time. We then compared modeling strategies, assessing whether a temporal modeling framework was really value added. And the results produced a pretty clear stepwise pattern in predictive performance. First, as expected, cross-sectional multimodal clinical plus morphology data improved performance over cross-sectional clinical data alone, increasing the AUC from 0.62 to 0.72. This confirms once again that multimodal integration adds meaningful predictive value. But the larger improvement came when we incorporated time. When we combined longitudinal trajectories of clinical and pathology variables, performance increased significantly to an AUC of 0.86. Now, the high-dimensional extreme gradient boosting method we used for these models included hundreds of features. It is not particularly practical as a bedside tool. So we next distilled the best, most interpretable predictors into an integrated rejection risk index, or IRI. IRI used just 4 clinical and 4 morphologic risk factor categories to assign encounters to low, intermediate, or high-risk groups. And those groups showed strikingly different rejection risk trajectories. Patients identified as high risk were more than 6 times as likely to develop rejection over the next 90 days, while low-risk patients had roughly half the risk of the reference population. Results like this begin to open up the possibility of real personalization in patient management plans. For a low-risk patient, this could mean fewer visits, fewer biopsies, and avoiding unnecessarily aggressive immunosuppression. While for those high-risk patients, it could mean closer monitoring, delaying immunosuppression weaning, or even trials of rejection abortive therapies. For the next experiment, I want to shift gears a bit and focus on a simpler data modality for just a moment. As we were developing IRI, we became curious whether we really needed a resource-intensive, high-resolution data source like a biopsy to generate clinically useful predictions, or whether a low-cost, widely available data source like an ECG could contribute meaningful information. By modeling AI-extracted longitudinal ECG features across visits, we recently found that ECGs encode a fairly strong and independent predictive signal for acute rejection. Stratifying patients via a binary ECG risk score, we identified a high-risk group which has a hazard ratio of 3 for future rejection over the next 90 days. Importantly, this signal is complementary to clinical data, with ECG data significantly improving risk prediction when added to conventional longitudinal clinical data modeling. And this is where things become translationally interesting. At a match sensitivity of 96%, the ECG-containing model allowed us to defer 15% of planned biopsies, compared to just 7% with the clinical data alone. Now, there is a bit of a trade-off here that both the clinical and ECG models did miss a small number of rejection events. They are not perfect modalities. But when you look at efficiency, the ECG model allowed us to defer 72 biopsies for each missed rejection event, compared to just 32 with longitudinal clinical data. So even if the rate of missed rejection is not quite good enough yet for confident real-world use, it clearly demonstrates the added predictive value of using AI tools to extract data from another underutilized data source, the ECG. This leads to a natural question. If ECG provides a low-cost signal and biopsies provide high-resolution detail, are these modalities redundant or are they complementary? We recently tested this using an end-to-end multimodal fusion model, combining ECG and biopsy embeddings in a single feature representation space. From a performance standpoint, we see a modest but significant improvement in C-index and model fit when we added the ECG data to the biopsy data, proving once again that different data sources capture non-overlapping predictive information. But I would argue that the more important take-home point here is the AI approach we use to do this. Instead of combining outputs from multiple distinct single modality AI pipelines as we did in previous experiments, our AI fusion architecture allows the model to discover cross-modal relationships directly from the raw, unstructured ECG and histology data sources. And this has important implications. It means we're no longer limited by the features we choose to extract, opening the door for AI systems which can continuously improve with more data and which can integrate new data modalities seamlessly in real time. So while combining our current single modality pipelines is probably the simplest and highest performing approach for near-term clinical deployment of AI tools, I believe it's these fusion models that will ultimately be the AI tools embedded in electronic health record systems 5 years from now. And that's because they can live within EHRs, incorporating every domain of digitized data housed within them and analyzing that data in real time, largely without supervision. So stepping back, there are three consistent themes which emerge as we reflect on these AI experiments in transplant medicine. First, no single data source captures everything. Different modalities describe different biological processes, and predictions are best when multimodal data is used. Second, trajectories matter, and data should be integrated over time to capture subtle trends. And third, real-world considerations of time, money, risk, and patient satisfaction are relevant when we think about how to implement new prediction tools. And we should think about future diagnostics hierarchically because of this. Low-cost signals like ECG, clinical data, and echoes should be used for screening, identifying those low-risk patients early and separating them from those who will need next-level testing. Then we have higher-cost but non-invasive screening tools like cell-free DNA or MRI, which are ideally suited for intermediate-risk patients. And finally, we have higher resolution invasive tools like the biopsy, which should be used for high-risk groups and when obtained should be leveraged for their full diagnostic and prognostic value rather than just assigning an acute rejection grade. This type of framework, thoughtfully designed by clinicians who know the field, but powered by AI, could enable a much more efficient and informative surveillance ecosystem for our patients. Because ultimately, the purpose of using AI in transplant is to help us move beyond protocol-driven care. The tools for enabling personalized transplant medicine are beginning to emerge. And by integrating routinely collected data and modeling it longitudinally, we can now envision a world where we tailor when to biopsy, when to escalate testing, and how to adjust immunosuppression, all based on individual patient risk. The remaining challenge is real-world implementation, but that's really a conversation for another seminar. With that, I'll wrap things up. Thanks for your attention.
Thank you so much, Elliot, for that excellent and very eye-opening presentation. As I said, we're going to leave the questions till the end, so please, everybody think about some questions that you have, because I think there's a lot of content there. Sorry. We'll move on to our next speaker, who, for many of the pathologists in the room, probably needs no introduction. So our second speaker today is Jan van der Sussen from the Netherlands. Jan is an associate professor and lead thoracic pathologist at Erasmus Medical Center in Rotterdam, where he currently also serves as the deputy head of the Department of Pathology and Clinical Bioinformatics. And I know that he will actually be taking over as the head in January 2027, so congratulations. Jan was trained in the UK and the Netherlands, and his research focuses on neoplastic and non-neoplastic thoracic diseases, with a particular interest in integrated computational and molecular pathology to advance personalized medicine. Thank you, Jan.
Thank you very much, Vanity, for that very kind introduction, and many thanks also to Elliot for setting the scene in a brilliant way. You'll see that we're nowhere near as far as the hard people have come in terms of developing AI tools in the lung, and perhaps I'll show you why that may be. So what do we have in lung transplant rejection assessment at the moment in terms of the sort of more classical features that we assess as pathologists? So we have the acute cellular rejection guidelines stemming already from the 1990s, which we still use, the A-type rejections on the acute cellular, the B in terms of bronchiolitis, the C in terms of obliterative bronchiolitis, and something that we hardly ever see is the D in terms of chronic vascular rejection in the biopsies. So we know a pretty limited kappa value when it comes to the inter-observer agreement for many of these features, and I'll show you that in a moment as well. It's perhaps even less rosy when it comes to the antibody-mediated rejection, where we have to use a multimodal approach, as Elliot has just mentioned as well, in terms of using both histology features as well as C4D in some cases, and DSAs if they're available as well, which may lead us to the diagnosis of antibody-mediated rejection. And there are other features which may actually also play a role in a patient's likelihood of rejection. So that could be things like acute fibrinous and organizing pneumonia or a diffuse alveolar damage that we see in the specimen, and which may in turn in the future lead to rejection of the organ. That's something that has not been fully crystallized yet, and certainly isn't really in the guidelines at the moment. If we look at the intra-observer reliability, there's some studies out there, and I'll draw your eye to the bottom one, where even looking at ACR, so acute cellular rejection, which is really the bread and butter of doing these lung transplant biopsies as pathologists, we only have a kappa value of 0.4, so that's at best moderate. To improve reproducibility, a few years ago at Banff, and I was also at the first meeting regarding this grid, the so-called Lasher grid, so the lung allograft standardized histological analysis grid that was introduced for standardized reporting. It's a little bit cumbersome perhaps for routine reporting, but at least it tries to introduce a little bit of harmonization into the reporting that we do. And you can already see that there's various features which we need to then score in terms of this grid. So there's a lot that can go on in the lung, and I look at both cardiac and lung transplant biopsies, and I know that from my own experience, there's so much more in terms of, for instance, recurrence of disease or infection that can also be at play, and which needs to be also recognized by any model that we build. So as Elliot has already mentioned, we're now way into the third revolution in pathology, so the digital pathology era, combined with artificial intelligence possibilities, such as the deep learning networks that we use mainly for many of these models that we build to recognize the features that we're interested in. And this has also been recognized by Banff itself. So in the 2022 report, lung report, it was already mentioned that AI may play a role in the future. So this is already a few years back. Here already also it was mentioned that a high quality multi-center data set of annotation serving as a ground truth is needed to achieve the desired accuracy of the outcome. So I think already recognizing at the time that it's important that we agree upon the input for these models. Now, there are a couple of studies which have focused on lung transplant rejection in terms of artificial intelligence on whole slide images. One of them coming out of the Duke group, which was a single center study with over 3,000 annotations made in regions of normal and A1, A2 rejection on H&E whole slide images. And this was trained to recognize mainly ACR and distinguish that from the surrounding lung tissue. I think that already points to a potential problem in that this model is only trained to recognize these acute cellular rejection features and distinguish that from everything else that's already going on in that graft. So I think that's one of the limitations. If you're looking at designing these models, at training these models, I think the ideal, of course, is that you would have something that recognizes all of the various histological appearances, but in reality, it is sometimes too difficult to do that in first instance. And that's borne out by the second study, which is one that many of us have been involved in, also some people on this call today, including myself. So that's the so-called DigiLut study that was initiated by the French group at FOC. And this was a challenge, really, a data challenge, meant as a data challenge, in which annotated lesions in a large set of lung transplant biopsies would be used as a data set for the data scientist community to create and improve an algorithm on this. And then each competitor would eventually be evaluated and ranked. So initially, of course, we started off with the slides, which were annotated by a large group of pathologists. There were over 2,000 transbronchial biopsies, with a standardized clinical report being used for case selection to also have as balanced a set as possible. They were H&E stained, and 5 to 10 biopsies were available for each case, and 4 to 8 levels were available, and 1 to 2 slides per case. These were digitized using 2 different types of scanners, and then an annotation was built by the group at FOC, which integrated this lasher grid that I just previously mentioned, and you can see how many different categories of features we were able to score. So I think that creates a problem for the data scientists, in that we have a problem which consists of over 20 different phenotypes that we can annotate. Then this allows us to draw a line around a region of interest, which then incorporates one of these features. That's used by then clicking on the button above the screen and annotating it with the relevant label. This is in a sense, a semantic segmentation, because we're teaching the system a pathology feature rather than telling it that within this slide there is acute cellular rejection. We're actually pointing the algorithm towards where the acute cellular rejection is going on. Just to give you a brief overview of the different ways of annotation. So if you do an agnostic annotation, or no annotation at all, you just tell the system, for instance, from the electronic health records, that there is a case of acute cellular rejection. It will recognize that as such, but it doesn't know which features necessarily correlate with that. Whereas if you do segmentation, what we've done, you actually point it towards the features that are known by pathologists as correlating with rejection. And then we draw this box around the feature. In this case was a perivascular infiltrate, which corresponded, of course, to acute cellular rejection. And there are some more examples here. That's actually quite easy to do within this annotation tool. Now then, there were 2 ways in which we assessed the data and actually also trained the pathologist. So in the first way, we had a scenario in which the pathologists were independently annotating the same biopsies, and then we had a training session in between, and then we had a second phase in which the same pathologist annotated different biopsies, and we just looked at the distribution of the various diagnoses and the various ROIs that we'd annotated. And something interesting happened. So after the first round of scoring, we could see that almost 3/4 of the biopsies showed no rejection according to the pathologist, whereas after the meeting that we had, that increased to almost half of patients having a rejection according to pathologists. So I think there's something interesting in terms of psychological differences going on, in that we all felt that perhaps we were underscoring in that first set. I mean, that's my interpretation, and we egged each other on to actually score more features, or perhaps be a little bit better at recognizing these features of ACR. So I think that's a real risk if you're doing these annotations without prior training, without prior harmonization. You may end up looking at having different thresholds for scoring for rejection. So in fact, and that was a little bit sobering, the kappa dropped after having that consensus meeting. So that's an interesting finding, I think, from that scenario. So in the second scenario, we again did the annotation in the first round, and then in the second round, in the first round we also cross-validated. So there was a group of pathologists who cross-validated these findings of the 6 participants, and in the second round we did the same. Again, we had a consensus meeting in between, and then using those confirmed annotations, we looked at the division again of the various lesions. So a lesion A was seen in 81% of cases, in those cases that were found to be evidence of rejection, and that was quite similar actually to the second phase. So I think the this is also an important message that if you do that type of cross-validation, you may end up with more trustworthy data. And in fact, the CAPA or the agreement in this case remained very much the same after the consensus meeting. And that was also split out for the various lesions. So acute cellular rejection, there was quite high agreement. And in fact, for the bronchiolitis, the agreement increased as it did for the obliterative bronchiolitis. And then eventually, these data, these annotated data, were uploaded onto a health data platform, and the slides were anonymized, and they were shared with the companies and the research groups which were taking part in the challenge. Then 3 came up as the top-ranked teams, but looking at the F1 score, which is really a combination of the precision and the recall score in machine learning, and which ranges from 0 to 1, 1 being the best, we can see that it's at best moderate again. So I think that may also be, again, perhaps a result of the balance of the data that we used, as well as the correctness of the annotation. So something that Elliot also mentioned, I think the end-to-end methodology, that's something that will also play a role in lung transplant rejection AI, in the sense that if we can just feed the model a large set of data with outcome measures, or at least perhaps orthogonal evidence of rejection, that may lead to more insight into which lesions actually are important, and that we should be looking for. So there's a degree of interpretability, as we know from some of these models, which in this case can tell whether something is a dog or a cat by just looking at the face of the animal. So something like that, I think, is something that could be incredibly important for our community, because we're working with a slightly antiquated system from the 1990s in terms of classification of the different lesions that we can see in these biopsies. Perhaps we just need a new way of thinking about lung transplant rejection pathology. So in summary, an easy annotation platform, we can agree on that, is necessary for supervised learning approaches. Calibration meetings are very useful, but in this case, we actually saw that there was a diagnostic shift towards higher A scores in the cases where we didn't use cross-validation. And perhaps too many different annotations were used in this case for the purpose of the study, creating a highly multi-class problem for the model design. And then the scenario 2, where we have the cross-validation, that might be better at actually training these sort of models. And I think in the end, an end-to-end AI may be preferable to predict outcome and offer interpretability, so that we can be friends with the AI again, and perhaps have, as Elliot also mentioned, a very bright future in incorporating this also into the practice of lung transplant rejection prediction. And these are the acknowledgements mainly for all of the people who took part also in being expert members of the annotators group.
Well, thank you very much, Jan, for this great perspective. And now I would like to broaden the discussion by inviting a colleague who works with medical imaging to share his perspective on how AI is transforming imaging. It is my pleasure to introduce Dr. Chandra Bortolotto, who is an associate professor of radiology at the University of Pavia. He has served on the board of the radiology informatics section of the Italian Society of Radiology, and he has contributed to various publications on AI and radiomics applications in thoracic oncology. So please, Chandra.
Thanks for the introduction. We're going to talk about imaging biomarkers today in thoracic transplant. So let's move to it's the last lecture of this very interesting program. We're going to subdivide my presentation into artificial intelligence and radiomics. So let's start with artificial intelligence. A lot has been said about artificial intelligence, but maybe since most of the audience is composed by pathologists, you may, and as I know, there's no radiology around, why should you care about radiology and AI, and what can the relationship between radiology and AI teach all of us? I guess maybe just the resilience to the AI hype. In 2017, Jeffrey Hinton said that within 5 years, deep learning will do better than radiologists. So we should stop training radiologists. Because also we have got plenty of radiologists already. Actually, after almost 10 years, we still survive and thrive. Jeffrey Hinton gets the Nobel Prize, but the mantra has slightly changed. Radiologists who take advantage of AI will replace radiologists who don't. So I guess that the perspective should be this. What about artificial intelligence and lung transplant? Artificial intelligence can enter in the pre-transplant phase, in the intra-transplant phase, in the early post-transplant phase, and the late post-transplant phase for predicting complications like PGD, CLAD, and monitoring and personalized treatment. Let's look at some interesting literature on several topics. Let's start with pre-transplant phase. We will see this article from 2024 from Ismail, in which they put in place a system to deliver precise standardized lung measurements on X-ray. Pretty cool, but actually, as pointed out in this editorial, they cite Ismail, but they also cite this old article which said that we actually should use CT to do this. So using AI for tasks which actually can be done better in another way. This is a multi-organ donor template we use in Pavia. As you can see, we measure, of course you are not capable, or at least you are not proficient in Italian, but as you can see, I underlined the section about the measurements on the lung thoracic cavity. So we actually use CT. So why try to use AI to extract this data from X-ray? We just need to focus on the important stuff. Focusing on the important stuff, in the post-transplant phase, a lot has been written and a lot of study talk about bronchiolitis obliterans. In 2017, this group led by Barbosa published a paper about the diagnosis made by AI of bronchiolitis obliterans. They get an AUC of 0.81, but actually the old radiologist, the SQS is semi-quantitative scoring made by the radiologist, gets an AUC of 0.76. So actually the delta is 0.05. We should really take into the arena AI to improve 0.05 over the radiologist. So pretty interestingly and also effectively, they move to prediction of onset. So they move from diagnosis to early diagnosis, which is more interesting because from a radiological perspective, we have very few tools to predict BOS development before time. For chronic lung allograft dysfunction, it's pretty much the same. A machine learning tool against radiologists for scoring lung texture and ground glass opacity, reticulation, and all the conventional radiological signs. Once again, they get good sensitivity, specificity, and accuracy, and AUC with the AI, but actually both the radiologist and the machine learning scoring are associating with the survival. So what the machine learning gives us in advance is the phenotype of the clot. Because as a matter of fact, biomarkers like pulmonary vessel volume, which are something that cannot be effectively evaluated by the radiologist because it's a quantitative measure which is complex complex to achieve only by the eye, is a strong predictor of clad phenotype. So in this setting, the AI is effective and is more effective than the human eye. Speaking of post-transplant phase, let's move to the early phase and see this article from Chow and colleague about the X-lung perfusion radiograph. They use AI to predict the evolution and the rejection and the survival of the graft from this radiograph, but actually they came out more with new radiological semiotics. So AI can also help a little to discover new semiotics into our images, rather than actually give us tool to replace our job. We as radiologists are actually pretty much in the app store level. This is the conventional app store from my wife's cell phone. As you can see, we have two kids, so it's pretty invaded by apps for kids. And this is an app store for radiologists. As you can see, there are more than 300 products already in the clinical stage for several modality and several subspecialty. You may ask, okay, but what is in the clinical practice? What's available for transplant? Nothing, or at least one tool which works on liver transplant. So there's nothing for the chest, there's nothing for the cardiac, there's nothing for the lung. Why? Because we need to bridge the gap. We usually work as radiologists in the lung transplant field. We work with small cohorts, smaller than what we are used to work with in other areas. We have a severe class imbalance because we work with relatively rare and with complex outcome definition. And we also, in several cases, we work in retrospective single center design, which is not good for big data. And also, I've not written it down, but actually another problem is that the companies are relatively not interested in this kind of tool because their use is pretty subspecialty. So it's complex to convince to develop this kind of tool from a company perspective. Let's move to the cardiac allograft. This is a 2022 systematic review. There's nothing in radiology. The only image-based context article is on histological slides. In 2025 and in the subsequent years, something has been published like this kind of article. In the pre-transplant phase, AI can help to automate the total volume of the cardiac, the measurement of the heart to obtain automatically. As you can see, this is something that generally is used to streamline the workflow in comparison to manual segmentation. So we are just speeding up what we do in clinical practice. We are not getting new information, but just trying to get the regular information faster. Let's move to radiomics in these last 5 minutes. It's an omics, so it uses large volume data which are extracted from the imaging. This is the guy who create the definition and the field, which is Lamben. He's actually not a radiologist, he's a radiotherapist. He said that the radiomics is an high throughput extraction of large amount of imaging features from radiographic images. So we extract those features which are something that goes beyond what's available to the human eye. Those features are mathematical features that are used to build diagnostic and predictive models. So you give this system the seed, and this system will tell you what flower will flourish from the seed. The radiomics process is pretty well established. We do image processing, then lesion segmentation, because of course we generally work with tumor to extract feature from tumors. Then there is the feature extraction, feature selection, model construction, and model validation. An important stuff is that for radiomics, you cannot use the regular image used into your daily practice. You need to do voxel resampling, normalization, intensity discretion, so you can feed those systems with the images you saw every day. You need to pre-process them. Then you have feature extraction. Features are subdivided into several classes. Morphological feature, very important for tumor, the size, the contours, the shape. Then intensity-based feature, which are related to the modality you use, and then those which are fundamental in the transplant area, the texture-based feature, because those texture apply also to organs. Another important stuff to say out loud is that radiomic is not AI and AI is not radiomic. Those are two different stuff. Radiomic can be done also by a human being, which creates image segmentation. Feature extraction is a mathematical process, so can be done also with a paper and a pen if you have enough time. Of course, most of the radiomic model are built up with the support of AI. Also, generally, we we conceive radiomics as tumor-based radiomics, so for focal lesion. But there is a new wave of radiomics which is organ-based and mainly relate on total volume of an organ and intervoxel relationship. Something has come out also in the lung transplant setting. As you can see, this is a very interesting article in which a rat lung transplantation model is used to predict allograft rejection with AI, and AI using radiomic feature. As you can see, the AUC is very high, but still SUVmax, which is a conventional kind of imaging biomarker extracted from PET-CT, positron emission tomography CT, still has a good correlation. So we just strengthen the power of what we already had. Also, this article introduced a very interesting use of radiomics, not on the organ itself, but to the patient, and especially in this case to the paravertebral muscles, so not lung but muscles. This is a kind of an opportunistic evaluation of the patient organ other than those which will be transplanted, and there are features which correlates with allograft rejection. This feature EMC2 is of course a textural feature. This scheme is the way this feature is computed from conventional matrices of intensity in CT. Actually, it's not as easy. In my opinion, is pretty much like Sudoku. So it's very complex from a mathematical point of view, but it shows you what's the texture of the organ involved. What about cardiac allograft and radiomics? Actually, we did this very interesting review, point out that radiomics should be assessed as a biomarker, but in a multi-omic profiling fashion. So we need to try to build multi-omic profiling. Also, because cardiac transplant research is still largely at the stage of CT, MRI conventional metrics, so the true radiomics texture feature pipeline is not fully applied to heart transplant. In conclusion, we try to apply big data to small serieses. This is complex. It's much more complex than in other areas, so we need a collaborative effort. We need to focus very strongly on actual interest in clinical need. If we want to speed up things, we need to work in that direction. If we want to do prediction, we need to use the correct tool. Just remember the use of X-ray to do something that we do actually on CT. Interesting that it works, but actually is out of scope. We need to use multi-omics, and maybe that's the reason why a radiologist is speaking during a mainly pathologist webinar. Omics should learn from each other. Pathomics is born around 2019, and radiomics is born in 2012. So it's slightly older than pathomics, and some stuff can be learned from radiomics itself, like the need for standardization of the image, of pre-treatment of the image. So, imaging biomarkers and AI in radiology of thoracic transplant, where are we standing? I actually don't know. You may know this GATNet hype cycle. You may have started this webinar in inflated expectation. Maybe as of now you are in disillusion. I don't know, but I hope you enjoy this ride into radiology and AI of transplant. Thank you for your attention.
Thank you so much, Chandra, for that excellent talk. And thank you to all three of the speakers. It's been exceptionally eye-opening on such a very topical issues. We're going to open the floor to questions, and as the moderator, I'm going to use that advantage to ask the first question. Elliot, I'm going to ask this specifically of you, but I'm very happy actually for all three speakers to give their input. And I'm just wondering, particularly since you've had both North American as well as Australian experience, and I'll ask the other speakers to comment on their experiences in Europe, but what do you think are the key barriers to implementing AI-based rejection surveillance in routine practice so it becomes sort of more accessible?
Yeah, good. Obviously, great and really great question, really the central question, right? I mean, why are we doing all of this research? And it's in the hopes of being able to eventually deploy it and use it for patients. There are several degrees of barrier. I think one barrier is operational and logistical. In order for these tools to be useful, they need to be in some way integrated into electronic medical record systems, or at least optimally, or the data needs to be ported from electronic medical record systems to a cloud-based AI platform. Those are sort of the two available options for doing this. They have different strengths and weaknesses. If they are going to be cloud-hosted AI tools like our large language models we all love, or whatever it may be, that is easier to execute than integration directly into electronic health records, but comes with privacy concerns and commercialization concerns and a bunch of other logistic and the actual physical task of uploading and porting data. On the other end, if it's embedded in electronic medical record systems, you have to have good electronic medical record systems, which in the US is perhaps a little further along than parts of Australia and in other parts of the world, but it's a necessary piece of the puzzle. And then you have to deal with the fact that you're operating within someone else's software, and that has licensing concerns and all kinds of other operational challenges. But it does provide direct access to the data that matters. So that's the operational logistic part of it. The other part of it is we need to make sure that the models are properly validated and that people believe they work, and sort out the regulatory environment that approves them for clinical deployment. And that, again, has somewhat country by country challenges. The FDA has some pathways now for digital pathology diagnostics. In Australia, there's no formalized pathway, but that can be done through HREC systems. But again, there are a few examples in the cancer space where clinical tools have been deployed on digital pathology workflows, so it's possible. There is a framework. I think now it's just a question of getting buy-in from everybody that they want this, and figuring out the operational steps. But that's really the challenge over the next couple of years now that the technology is close to mature, is how do we move it from papers to people?
Yeah.
Well, thank you. The question I would like to ask it to Jan, but obviously this question can be useful also for a discussion with also the other speakers. What are the benefits and challenges of using unsupervised learning or end-to-end models? Because it is something that I was always thinking about, and I would like to discuss with you what benefits and challenges, please.
Yeah, thank you. That's a very good question, Francesca. I'm a big fan of end-to-end modeling because I think it teaches us a lot about the biology and the underlying physiology of the disease that we're dealing with under the microscope in our case as pathologists. And that really broadens the scope of what we've been doing for years, potentially with the benefit of finding new features which may perhaps be even more reproducible to score by us. So that's my hope when it comes to end-to-end modeling. I think one of the drawbacks is that it is very data hungry. So you do need a large data set which is appropriately curated and which has very good outcome data in terms of rejection, graft failure, etc. And it also shouldn't be too unbalanced, sorry. So something that we deal with when we're training these models is that, for instance, if you're doing surveillance biopsies in the lung, you will have a complete shift of balance towards the normal tissue. So you need to have a balanced data set to actually give you the answers that you need, because otherwise you're always going to also have that bias in terms of the performance of the model. But I think there's great potential in these end-to-end models.
Okay. Just looking to see, do we have any questions from anyone in the chat or in the audience? If not, I'm going to ask another question actually for Chandra. And I was just wondering, because as you mentioned, radiomics has been more developed and has started off early. And what do you think other imaging omics can learn from the positives and the negatives in your experience?
Yeah, some stuff has already been said during my presentation.
Yep.
But I think that those are important concept. Radiomics and also AI are very fragile, actually. If I can say something about what Elliot discussed, is how many of these research, which generally are monocentric, retrospective, creates those systems with very high AUC and then report prospective application even in their own hospital. Just, I don't know, 6 months of prospective reporting feasibility. No one does that. Generally, we get very high AUC, and that's it. That's it. We don't care about doing more because those systems are fragile. They won't work very well in perspective. And radiomics is even more fragile. So we need to have standardization. There is the IPSI compliance, the Imaging Biomarker Standardization Initiative, which also apply to pathology. So it's not just for radiologists, it's for imaging in all its perspectives, also for pathologists. So a lot of standardization, but when you apply strictly standardization as proposed by the IPSI, generally you have a drop in your performances. So the strings come out, as we said in Italy. You see what's underneath. So if you want to publish, you need to have very high AUC, especially in this area. If you report strict standardization, and if you report perspective application, you have low AUC. So in my opinion, the main problem is the fragility of this tool. Of course, everything that is fragile but works needs to be cared and needs to be developed. So it's not like something that it's irreversible. But as of now, those systems are very fragile.
Thank you. I'm looking to see Francesca. Oh,
yeah, I see in the chat there are no questions. I don't know if someone wants to ask something. Otherwise, I had a doubt, but maybe it's because I'm not so addicted to these technologies. So I hope that Elliot and Jan can tell me something about how can we annotate in the best way when we train an algorithm, or when we try to design an algorithm for a post-transplant pathology, for example. I mean, it is better to have more pathologists that annotate also with different levels of experience, or it is better to have very few people with the highest level of experience that annotate. I mean, what is the best way to have the ground truth for algorithm and for artificial intelligence in post-transplant pathology, in your opinion?
I'll take a stab at it. I think you'll get different answers from different people with a question like that, which is sort of fun, actually. I would, in a perfect world, I'd have multiple annotators. I would have them annotate however they felt best. I don't want to overly specify how they do that. And especially if I have multiple annotators as an option, because ultimately I kind of want to mine and model the heterogeneity. I want diverse perspectives. I want diverse ways of identifying things. I want agreement and disagreement. And ideally, I'd ask my annotators to also use some sort of confidence scoring when they're annotating things. So I would actually ask them to do some sort of ordinal confidence score, 1 to 3 or 1 to 5 on the features they annotate. That way, you fed the model diverse perspectives, different ways of identifying and circling those objects, and the confidence with which they've labeled it. And that's actually all useful data. And I would want all of that, because that actually will probably build a more robust model.
Yeah, sure, I'll give the same answer. So I think that is useful to have different people annotate, but I think we do need to agree on what the ground truth is, right? So the way we get there is one thing, but the other thing is that, what is a specific lesion and how do we identify that? So I think that's something that, I try to address in my talk as well. I think if we lack that clear idea of what the ground truth is, you'll have people annotating it in different ways. And that will, in the end, I think, confuse the system.
actually, Jan, I was going to ask a quick question. In your talk, you mentioned, you went pre and post from the higher number of people agreeing on rejection, but then the kappa value dropped. So, but I thought it was interesting. It's actually quite heartwarming to think, that the concept of, that whole pathologist getting together, maybe that we do need this data set. I was just wondering how you sort of interpreted the fact that the kappa score went down, but even though it seemed that there was greater concordance between the pathologists.
Yeah, I think that's not unusual, even sort of before the era of machine learning. I think that also, for instance, there's a great study out there looking at confidence around ILD diagnosis, both by pathologists and radiologists, and then with more training, some people become less certain, and that's perhaps human because you're being shown a mirror, right? So you've done something in a certain way for perhaps 10 or 20 years. Nobody's ever sort of dared question your diagnosis because you work in that big center. But I think something that I learned out of this is that it would be really useful to have these sort of meetings more regularly, perhaps even outside of the context of training deep learning models, but to just have, within our community, perhaps now and again, just show each other difficult cases, see how you deal with those, what is the ground truth, and is there a ground truth that you can find for a specific case? But I think that just shows us that we're not perfect as pathologists, and there's psychology in everything that we do.
Yeah, I agree. just looking. I can't see any more questions, hands up or in the chat. And I think we've sort of come to the end of our hour. Francesca, do you have any more questions, or did you want to?
I think that also other people that want to give other questions to the speakers can connect with us also by ISHLT Connect or by email, because I think that this topic is really something that cannot be completely described and discussed only in 1 hour. But I think that a lot of very important messages we can take home. One of that also Chandra underlined, highlighted during his presentation, is that we must not, in my opinion, we don't have to think about artificial intelligence as something that can substitute our professionals, so pathologists and radiologists in this case, or other professionals, in particular in the transplant field. But we must take in mind that it is something that can help, that can increase the reproducibility of our evaluation, and also in order to give some kind of help to less trained, less skilled pathologists or radiologists. Why not? Not all the pathologists are and the radiologists are so skilled. So I think that artificial intelligence can also help in training, in increase the reproducibility. And I think that it is the best way to give more to our transplanted patients, so to go even more on forward on this field. So I think that a lot of very important messages came from your great talks, and I thank you. I congratulate with the speakers, and also I thank the attendees for being here, despite the timing that is very late for European, it is very early for the Australian, but I thank you so much for being here to discuss. And I don't know if Vanati wants to add something.
I just, again, wanted to thank the 3 speakers. It was very eye-opening, very topical. I learnt a lot, and I'm an AI novice, so I really, and as someone who is not quite sure where we're going, but I think the reassurance is that the concept that it's going to improve our ability to give patients reproducible and accurate diagnoses, I think is, how we have to learn from this. And yeah, thank you for your time, and also thank you, Francesca, for coming up with this idea and putting the talks together, like putting the speakers together. So, and through the rest of the committee. And again, thank you everyone who joined in, and also those, as Francesca mentioned, who have questions, burning questions later on, can put them in the ISHLT Connect, and I'm sure our speakers will be able to respond to them. I think on that lovely note, it's a beautiful sunrise out here in Sydney this morning. I'm hoping, Elliot, you've got a lovely sunrise there in Brisbane. For the rest of you, have a really good evening. And yes, goodbye, and look out for further webinars on ISHLT. I know the heart failure will be putting out one coming up soon, and I think lung will also put out one as well. So looking forward to seeing you all and looking forward to seeing everybody hopefully in person in sunny Sydney next year in April. So on that note, I think we can finish the meeting. Thank you all very much.
Thank you. Bye.